I am going to talk sense the glucose and pump in insulin. I have no financial disclosure for this talk. I'm going to talk in next 20 minutes about the sensor and pumps. The challenges in diabetes care, the biggest challenge is we know that 70% of our patients are uncontrolled. But technology used in our health system overall, as well as in diabetes, is very, very low. And one very big challenge, the care for type 1 diabetes is very, very poor. Now this care for type 1, as far as health system is concerned, the government is not sufficiently, they are taking care of these type 1 children. But I would like to say that from classroom to clinic, the care for type 1 is poor. Why I am saying is, neither are medical school who are teaching for the type 1 kids they should be taken care, neither to the pediatric department nor in internal medicine. And at the same time, even I am organizing also many big conferences, but we don't teach and we don't have a dedicated symposia, dedicated program on a type 1 diabetes. Even you see this type of big meeting, we have hardly a symposia of less than 30, 40 minutes or 60 minutes. So from classroom to clinic, the care is really very, very poor. And that's the reason even we have highest number of type 1 children. After the second highest than US, still the care of these children are very, very poor. The glucose control in diabetes is very, very important. It is the only goal. We don't want our patient neither to develop hypoglycemia nor hypoglycemia. But glycemic control reduces the complication. This we all know from our DCCT trial. But this is very interesting. If you just see that to achieve a HbA1c of 7, the one type 1 kids has to have a 60% chances that he will develop a significant or severe hypoglycemia, even hospitalization for hypoglycemia. So the 60% of these kids who have developed the hypoglycemia to achieve HbA1c of less than 7, and this is the real situation. So glucose monitoring is must. It is not only for type 1, but it is equally important for person with type 2 diabetes also. SMBG or a randomly lab testing of a sugar is insufficient to keep a tight glycemic control. And mainly when I am talking of tight glycemic control, it is without hypoglycemia. So I want to achieve a HbA1c of less than 6.5 or 7, but at the same time, he or she should not develop hypoglycemia also. The limitation of a current monitoring method, either we have a A1C, which is going to tell you what happened to the last 3 months. So we are going to have an idea that what happened to the last 3 months. If somebody is having uncontrolled diabetes, it means last 3 months patient sugar is uncontrolled. And whatever the changes which we are going to make now, it is going to show you again after 3 months whether patient sugar is controlled or not. Or other is a self-monitoring or randomly blood glucose which they are getting through lab. So when we monitor through HbA1c, even the two patients may have a same HbA1c, but still the number of hypo and hyper may be different in both these patients. And one of the example with a tight glycemic control patient, you may have even less than 7, but other patients may have even more than 50% of the chance he or she may develop a hypoglycemia also. The limitation of a logbook, which is with SMBG, most of our patients will come with such type of a randomly done blood glucose monitoring, which is written either in a piece of paper or something like that. And it is really very difficult to interpret this type of testing blood glucose report. It is very much because physicians are so busy, they have an inadequate time to detect patterns in a handwritten logbooks during a short office visit. To understand that how much relationship and HbA1c, if somebody have to achieve a good tight glycemic control in patient who is insulin taking. I don't have the data for a patient who is not insulin, whether a type 1 or a type 2 who is on insulin. A patient who is doing a self-monitoring of blood glucose more than 7 times or 8 times in a day, then he can achieve a tight glycemic control, whether patient on a multiple daily insulin injection or patient is on a continuous glucose monitoring. Do you think it's a good way? So how long we are going to measure our blood glucose, the way by which we are doing through self-monitoring or by the lab reports? I think it's a time now we have to think beyond HbA1c or beyond glucose monitoring which we are doing through self-monitoring. A continuous glucose monitoring technology is really changed. It's the greatest innovation. Please see that it's the greatest innovation in last 13 years, and whatever the innovation had happened in field of technology in diabetes, I think is maximum in continuous glucose monitoring. And in 3 years, when we were having the Libre Pro before 3 years, it has completely changed the therapy, what we used to do pre-Libre and post-Libre. So the Libre has really changed my practice also and many of our colleagues across the country. The efficacy of sensor-augmented pump. So even some patient may be on pump. I have more than 200 of my patients who are on pump therapy, but hardly less than 30 or 40 patients are on a continuously sensor-augmented pump therapy. So unless a patient is doing a continuous glucose monitoring, a pump person may buy just for the convenience because patient does not want 4 shots, 6 shots in a day, and that's the reason he or she had purchased the pump. But unless they do a sensor-augmented pump therapy or a continuous glucose monitoring, to achieve a tight glycemic control is real difficult. Before AZP came in market, we were having continuous glucose monitor by Medtronic, and even the Dexcom was there, but it was real difficult to interpret the data. But then we had got an ambulatory glucose profile, which is much easier. It comes in a graphical form. It also gives you an idea, the median. It also gives the hyperglycemia and hypoglycemia peak. It is done for a 14 days. You can get in between also. We normally call our patients in between also to get 2 graphs, because it can give after 6 days a graph can be, you can get the graph from a AZP. And it also gives that when you want to see that AZP graph overall, the first thing which you want to see that what is the pattern of hypoglycemia, what is the shape of the median curve, and what is the variability. And this is what we want to know from the AZP graph, but it is very, very easy to interpret because the graphical presentation is much easier in compared to the CGM data. One of very interesting patient which I want to show here, this patient had come to me, and this patient was having a HbA1c of 8.5 with a triple drug. This patient was already on metformin, he was already on sulfonylurea, and third drug was already on DPP-4. And this patient, as per the international recommendation, if patient HbA1c is more than 8 or 8.5 with a triple drug therapy with a submaximal dose, patient has to be on insulin. I mean, there was no reason why patient should not be on insulin. When we asked the patient, we had done the AZP ambulatory glucose profile just to teach and educate the patient, and then what we had seen, even the fasting sugar is coming more than 150, and most of the post-meal sugar are coming more than 200. I just added a alpha glucosidase inhibitor. We educated the patient, and you can see, because this is the unique way of using ambulatory glucose profile in our clinic, because we call the patient every 5th day or 6th day just to get the graph and to teach or educate the patient. And you can see on 6th day onward, when we added the alpha glucosidase inhibitor, you can see on 6th, 7th, 8th, 9th or 10th day, the graph started coming down. Even this patient on a triple drug therapy, I had used the 4th drug with no international guideline is talking. So we had added a 4th drug, and then you can see on 14th day, the patient was in a completely in a control, the time in range, which is, I mean, most of the time patient sugar was, fasting was also coming down almost like 90, and post-meal was sugar was 120. One other patient, yesterday also I had shown the same slide because this is only for breakfast. I have not done anything for this particular patient. We had just changed the breakfast for this patient because the only post-breakfast hyperglycemia was there. And what I have done is the content of the breakfast we changed. I explained what you should eat in the breakfast, rather to stop the breakfast. We should not have a simple carbohydrate. And you can see onward 8th and 9th day, the patient post-meal, all sugars had started coming down. So it can be a very good educational tool, motivational tool, and in some of the places, it can be used as when you are deciding the 4th line, 5th line therapy, or when to use GLP-1, when to start the insulin, whether a premix insulin, whether it's a long-acting insulin, that can be used in type 2 diabetic patients. So I had talked about the continuous glucose monitoring, more benefit definitely in type 1, but now we have an ambulatory glucose profile, which is a cost-effective for our country. We can use for our type 2 diabetic patients also in selected group of patients, and when it can be useful even though they are not taking insulin also. We have published one of our article in JAPI, the use of AZP for improving monitoring as well as managing the type 2 diabetic patients, where we had talked about it provides the doctor with an opportunity to have a complete glycemic picture of a patient. It offers a reliable, predictive, standardized visualization of the glucose data. We were able not only to reduce the glycemic variability, but also able to improve the quality of life with reducing the frequency of hypoglycemia. This was the conclusion for that patient. I was the part of this ATTD group February 2019 at Berlin, where the consensus on time in range target was there. I was the only Indian who was in the part of this time in range target, which was published this year in Diabetes Care. Also, they talk not only type 1, it's also type 2 diabetic patient should achieve a time in range. And in my practice, I talk to my patient, it's not time in range, it's a glucose in range, which they understand much better. So time in range means more than 70% of the time their sugar should be between 70 to 180, and that is what we want for our maximum number of patients. But hypoglycemia range, which is below 54, that one should not develop, neither type 1 nor type 2 diabetic patient, and that is what time in range. If you see a type 1 diabetic patient whose HbA1c is less than 7, and what we are achieving, what we are targeting, a type 1 should have a less than 7. If your patient who is with 7 HbA1c, and if you do a continuous glucose monitoring of this patient of last 3 months, and then you download the data, you will be surprised this patient was having only 47% of his time was in time in range. Even he is achieving a HbA1c of less than 7. So I mean, even you are achieving a target HbA1c for your patient, but still less than 50% of the time the patient is actually in time in range. Now let me talk few things about the pumps, because the topic is very big, sensors and pumps. So I have to finish in next 8 minutes about the pump therapy. This is how the injection therapy. A type 1 kid, just think of it, he or she has to take 1460 shots in a year if she is or he is taking 4 shots in a day. Please mind that 4 shots in a day, and how long she has to continue. This is really a crude way. The insulin delivery modes, if you just see the insulin delivery mode in last 20 and 30 years, the maximum technology innovations is happened only in insulin delivery method. Whether you talk of insulin syringe, pumps in pediatric, sensor augmented, or even automated insulin delivery system which had come. So what is the biggest advantage of continuous subcutaneous insulin infusion pump? Many of you will say that one of the biggest example that type 1 or even type 2, the basal requirement of a patient may not be flat all the time. Suppose if you are taking 24 units of a glargine or even a longer acting insulin, it does not mean your body requires only 1 unit per hour. I mean, different times of the day, when night time your requirement may be low, in daytime it may be higher, early morning may be higher. So one of the biggest advantages of continuous subcutaneous insulin infusion pump, you can change the rate of basal. But this I am sure many of us know. But this one more study which I want to show you, that those patients who want to achieve really tight glycemic control, it's not just the basal insulin. How many number of bolus shots one is taking, which is directly correlated with lesser the HbA1c. So you can see the patient who is taking more than 4 to 6 shots in a day, short acting, or more than 7 to 8 shots in a day, they are achieving a target glycemic control near around 7.7. So it's not just the basal dose which we want to get from CSII, we want to get number of bolus also. So if my patient is on a pump, a patient can have also 6 shots in a day, 7 shots in a day, and whatever the number of times he is eating or snacking, he can take the insulin shots, and that's the reason the pump is required for many of our type 1 diabetic patients. I also want to show one of the German registry data, which Dr. Thomas Dane had shared this slide with me. In 1995, they were using their less than 30% of the patients were using 1 or 2 shots in a day. While in those time also in 1995, they were taking 4 to 6 shots in a day. I mean, that is what NPH and regular. What in India we are using still in 2018, 2 shots in a day, that is premix. If you just see the German data, in 2005 onwards, there is hardly a single patient who is on a 2 shots in a day. Even the 3 shots in a day, hardly less than 10% of the patient. Still 50% of the patients, they are using multiple daily insulin injection in Germany as a type 1 diabetic patients, but the number of shots are 4 to 6 in a day, while the insulin pump usage started increasing after 2002 or 2001, and now almost 50% of the patients are on insulin pump. And if somebody is below the age of 5, he has to be on insulin pump, which is a myth for India that pediatric or very young age patients cannot be on pump. The insulin pump in India, the journey is, it is available since last 2003, but still less than 10,000 patients are on pump. And you will be surprised, out of them only 4,000 patients are on type 1, and those patients who are on type 1, only 2,000 patients are below the age of 15, and in 2,000 only 200 patients are on a sensor augmented pump. And these sensor augmented pump, how many of them are really using continuous sensor? That's really a big question. And we have second highest number of type 1 diabetic patients in the world. One of the biggest concern for our patients, many of the even physician and consultant, they feel that if patient is on pump, that increases the chances of diabetic ketoacidosis. Yes, theoretically it could be right, because there could be a possibility block and this can lead to decay, but this is not true, because in the data it shows that those patients on pump, they relatively have less diabetic ketoacidosis. The second question always comes the cost effectiveness, and there are papers on multiple papers was there which was published in different technology conference that these newer technology are really cost effective. So you please think that how cost effective for a patient to have an insulin pump. The simple thing which I can tell you, all these patients who are not using a good therapy or multiple daily insulin injection or pump, they don't survive after the age of 30. How many of you are having a type 1 diabetic patient who is coming to you or your center or your hospital more than 50 years? I can tell you, you will not able to have even one patient or two patients. Even in your city, if you put an advertisement, I have done it in 2002 in Insulin Day, and a paper advertisement I have done on a newspaper that if somebody is taking insulin for more than 50 years, we want to felicitate the guy. And we could find only one person in Ahmedabad with a population of 5 million. So I mean, this is the scenario, and most of the type 1 who are developing type 1 in pediatric age group, probably they don't survive more than 30 and 40. There are many expert opinion from India also. We have also done the guideline, pump therapy guidelines, consensus, everything has been done, but no, the endorsement from the government side or ICMR or from DCGI is not been done. The European Society of Pediatric Endocrinology and SPAD had given the recommendation who should be on the pump therapy, and the same way we had also done from the RSSDI and Diabetes India too. So how technology is useful? This is a very interesting paper which we had found. As I told you already in DCCT trial, in 1983 to achieve a HbA1c of less than 7, 60% of the patient develop severe hypoglycemia. When you see in 2008, a similar type of paper was published by JDRF, a continuous glucose monitoring along with the pump, and 20% of the patients develop the hypoglycemia also. In 2016, one more trial has been done which is pivotal, where they had used the sensor augmented pump along with the continuous sensor augmentation pump, and they have developed 0%. All these patients, none of them had developed a hypoglycemia. These were the patients and achieving a target HbA1c of less than 7, and that's the biggest advantage of technology to this mankind and to these diabetic patients. So my conclusion is diabetes technology is evolving. If you go from the 1921 or 22 from the glass syringe to we had come to the disposable syringe, we had come to the pen device, we had come to the continuous subcutaneous insulin infusion pump, micro pump, sensor augmented pump, and now we are moving towards the artificial pancreas or a automated insulin delivery, which had already come. The low glycemia, it already stops, which is already 640 and 670 G, which is also available in our country. To conclude my talk, pumps offer a high flexibility of insulin delivery with low rates of hypoglycemia and decay in well-educated patients. Sensor allow assessment of a time in range as a patient relevant parameter of glucose monitoring beyond HbA1c. Flexible insulin delivery based on CGM reading with pump with or without predictive low glucose suspend or hybrid closed loop appear most likely to enable our patients to meet individual time in range targets. Automated solution for glucose pattern analysis resulting in a closed loop delivery or diabetes treatment advice are on the horizon. Probably in next 2-3 years, we will be having a complete automatic system for the pump therapy also. So which system for which type of patient? This is again a slide which has been published in this ATTD, that blood glucose self-monitoring patients who are type 2 diabetic patients who are without risk for hypoglycemia, they can do randomly. The flash glucose monitoring patients where we want hypoglycemia reduction and time, improving the time in range for a type 2 diabetic patients on a oral anti-diabetic patients. The continuous glucose monitoring with the pump therapy like a pregnancy, hypoglycemia unawareness, and particularly athletics patients, or the sensor augmented pump therapy with hypoprotection, the very pediatric population where we can have, and we will have in future the hybrid closed loop also. In this 2019 American Diabetic Association had put a separate section on a diabetes and technology. And they talked about the technology is such an important thing, and they had talked about the continuous glucose monitoring, they talked about the insulin pump therapy, not only for type 1, for type 2 diabetic patients. And please go through for this year, American Diabetic Association 2019, about the technology also. So my take-home message, it's important to make technology sufficiently cost-effective. And this is very important when we are talking from Indian point of view. But please, whatever number of patients which you have, 20% of them, they are very, very affording. And those who are practice in private, I am sure they are very, very affording. If some patient is coming to my clinic who is paying me 1,500 rupees as a consulting charge, I am sure he is affording, otherwise he can't come to my clinic. So they are very affording class of patient. You please tell your patient that this therapy is available. And at least you tell the patient that this is available. And it's our ethical duty also that we must tell that these are the things which are available. Patient may or may not accept it. So people to adopt it so they can get on the next step in a diabetes management. With this, I once again, thanks to Nita and Sanjay to give a topic which is related to type 1 and technology. Once again, thanks to all of you. Thank you.